coming to the endotracheal tube, it is a device or that is inserted through the larynx into the trachea to convey gas and vapors to and away from the lungs. So it is a device mainly which helps in ventilations to convey or to deliver different types of gases, anesthetic gases also, and also to remove different types of gases like CO2 from the trachea and from the lungs through the trachea. Okay. So coming to the parts of endotracheal tube. So parts. Whenever you hold endotracheal tube in the viva, the first question is name the parts of the endotracheal tubes. So here the parts of the endotracheal tubes divided in two parts. One is the machine end, another one is the patient end. In the machine end, we have a standard adapter that is 14 to 50 millimeter in diameter. It is made of the PVC. It is a radio marker line from the proximal end to the distal end of the tube. The tube has a specific curve that is known as McGill curve, that is around 140 millimeter plus minus. We have a pilot balloon here. This pilot balloon had a single loaded, spring loaded one-way valve from which we can give air to increase the volume of this curve. Here there is an additional opening besides this bevel end opening and the distal end. We have another opening that is a Morphy's eye. That is the additional opening, and we have a cuff. We have this mark, black color mark, that is the vocal cord guide. That means this tube should be cross the vocal cord, and there is a radio opaque line through and through the tubes. In the tubes, this is marking 18, 20, 22, 24. Oral and nasal. It may be used for the oral endotracheal tube or maybe nasal endotracheal tube intubations. Size is 8.0, internal diameter is 8.0, and this 18, 20 is on the centimeters. So these are the parts of the endotracheal tube. Okay. So normally patient end, bevel end, Murphy's end, curve of the tube, markings on the tube, machine end, and tracheal cuff. Okay, fine. So coming to the patient end of the tube, we have a bevel end. Why this tube is as a bevel end? This slanted portion of the distal end faces to the left mainly when it is held in an anatomical position. It is faces to the left when the tube is held in the anatomical position. Usually inserted from the right side. Most of the anesthetists or most of the laryngoscopists are the right-handed persons. So they insert the tube from the right side. So this bevel end placed to the left to visualize the larynx properly. The angle of the bevel, mostly asked in the OSCE, that is 38 plus minus 10. It reduces the nasal morbidity during the nasotracheal intubations. As because it is slanted bevels and it is non-cutting or non-traumatized, it will hardly cause any injury to the nasal mucosas when inserted properly. Okay. Coming to the Murphy's eye. Murphy's eye is a hole in the wall opposite to the bevel. Suppose this bevel is faced towards the right, the Murphy's eye is towards the right. Okay. So the tube of the Murphy's eye is known as Murphy's eye tube. The tube which contains the Murphy's eye, they are known as Murphy's eye tube, and the tube lacking Murphy's eye are known as McGill type tubes. Okay, these are also questions. What is the advantage and disadvantage of this Murphy's eye? Advantage: in case of the blockage of the bevel end, it provides a secondary port of the gas movement in and out of the tube. That means it is an additional source of ventilations. Disadvantage: sometimes we insert the McGill forceps. Sometimes we insert the fibroscope. So sometimes what happened? This McGill forceps will be stuck in the Murphy's eye. This fiber optic scope will be stuck in the Murphy's eye and may get caught into it. Sometimes secretions may accumulate in the eye itself. But advantage is mainly when the bevel end is blocked, it will provide another source of ventilations and the tube will be not blocked completely because of the presence of this Murphy's eye.